And see, there's a little play on words there. It's lighter in weight. You know, I hate to have to explain jokes. Okay.
Got it.
Woo! Yikes. This is a tough crowd. All right.
Sorry, Dr. Penner, I know you can usually count on me to laugh, but I didn't get that one.
Well, you know what?
I think you're still registering.
I put this little cartoon in here, and I'm sorry I did it, but because it reminded me of something clinically that happened to me. Okay? So the physician's telling the patient who's old and hard of hearing, he says, yes, that was very loud, but I said I wanted to hear your heart. Okay. Right, there you go. One time, and this is a true story, one time had a stethoscope listening to the lungs of this elderly lady. And she wasn't taking deep enough breaths so I could hear her breath sound. So I kind of yelled to her, big breaths. You know, I wanted her to take big breaths. And she said, oh, honey, you should have seen me when I was younger. All right. So let's suppose we have a patient in the morgue, okay, and we were to open up the sternum, okay, and retract the rib cage like this. Would we actually see the heart? No. It would be covered by this pericardial sac. Okay. Now, in your book, they talk about a fibrous pericardium and the serous pericardium. When we drew this picture with the visceral layer and the parietal layer, those are parts of the serous pericardium. Actually, outside of that sac, there is a second layer of tissue made up of dense connective tissue that connects the pericardial sac to the surrounding structures, like the diaphragm here. This is fibrous, thick tissue. Some people refer to this additional layer as the fibrous pericardium. Okay. And the serous pericardium, which we'll demonstrate here, sits inside or deep to that. Unless we say otherwise, when we use the term pericardium, we're talking about the serous pericardium with those two layers, the parietal layer and the visceral layer. So when we first open up the mediastinum here, we would have to cut through the parietal pericardium in order to see the heart. And that's what's been done here. We've created a window through the parietal pericardium to look at the surface of the heart. Now, notice that the heart has kind of a glistening appearance here. The only reason it's got this glistening appearance is because that layer of epicardium. That visceral layer of the pericardium, or the epicardium, okay, gives the surface of the heart a glistening appearance. If I were to strip off this epicardium so that we then reach the myocardial layer, it would appear the tissue would look dull. Now, this picture is kind of deceiving because it looks like the pulmonary trunk and aorta are sitting side by side. That's not truly the case. The pulmonary trunk sits in front of the ascending aorta. So that's the only beef I have with this picture. This would be the superior vena cava coming down into the right atrium. We don't see the inferior vena cava, but this is certainly the right atrium. Now, both the right and left atrium have this little ear-like component that extends from the atrium. This is called the right atrial appendage, or some folks will call this the right auricle. And auricle means ear. So the right auricle or right atrial appendage is just part of the right atrium. Now, let's look below it. This is the right ventricle. Okay. The right ventricle contributes to the anterior wall of the heart. When the right ventricle pumps and injects blood, it does so up into the pulmonary trunk. Again, remember that the pulmonary trunk is the anterior-most great vessel. So again, when trying to orient yourself, okay, remember that the pulmonary trunk sits the furthest front, along the front aspect of the heart. So when the right ventricle contracts, it's going to inject blood up into this pulmonary trunk. Here's that fat-filled groove that sits between the right atrium and right ventricle. I can call this the right AV sulcus or the right coronary sulcus. And the reason I call it the coronary sulcus is because the right coronary artery is coming off the ascending aorta and traveling all along this groove toward the back of the heart. Okay? This other fat-filled groove here would be called the anterior interventricular sulcus. Earlier we said that the LAD is going to travel down this sulcus toward the apex. Remember that the LAD, the left anterior descending coronary artery, is one of the branches of the left main coronary artery. The left main is coming from the left side of the aorta. And we said it splits into an LAD and then the other branch is a circumflex. Okay. On the other side of the anterior interventricular sulcus here, left ventricle, it contributes here to the apex. When the left ventricle contracts, it's going to inject blood up behind the pulmonary trunk into the ascending aorta. This blood is going to be oxygenated. Now, these nerves coming down are part of the vagus, the wanderer. Okay? Remember, the cranial nerves carry parasympathetic fibers. These parasympathetic fibers can slow down the heart.
It's funny how I hear that song every time you say that.
Yeah, that's the wanderer. It's the wanderer. Goes around, 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 around it. I'm the kind of guy. You know, I like that song too. I can't help it. I thought,
I don't want to hear the same again.
Yeah, I can. All right. So we've opened up the heart here. I know immediately that this is the right ventricle because of the thinner free wall. Left ventricle. Okay. We've just opened up the heart, right ventricle, left ventricle, like a book. Okay. Notice that these are the AV valves. The AV valves have cusp, chordiotympany, and papillary muscles. Okay. The one on the right side, tricuspid. The one on the left, mitral. Now, this is the left ventricle. When it contracts during systole, this valve is going to close, and so the only place blood has to go is through this left ventricular outflow tract into the aorta. So this valve, this semilunar valve that sits at the base of the aorta, we call it the aortic valve, it has to open during systole. It's got to allow blood to flow up into the aorta. Both semilunar valves, by the way, have 3 cusps. 1.5, this is the second half, so this is 2, 3. Okay? They're called semilunar because they look like crescent moons extending from the wall of the great vessel. Notice just above the aortic valve, these are the 2 coronary ostia, the openings into the coronary arteries. Okay? On the right side, this would be the right coronary ostium. On the left side, this is one toward the right ventricle. On the left side, this would be the left main coronary ostium. Now, when blood is ejected into the ascending aorta, this cusp opens and partially blocks flow into the coronary arteries. So how do coronary arteries fill with blood? It turns out that the coronary arteries are the only arteries that fill during diastole. So it's only when blood starts to move back toward the valve and the valve closes that then fills up these coronary arteries. So that's an important thing to know, is that the coronary arteries fill during diastole. Every other artery in the body fills during systole when blood is being ejected into the aorta and its branches. Now, these are papillary muscles here. Here, you see how there's two papillary muscles here. These ridges, made up of myocardial beams, if you will. We refer to these ridges along the inner wall of the ventricle as trabeculae corneae. It's in your book.
It's in the book.
All right, now the ridges along the atria are not called trabeculae corneae. Those are called pectinate muscle. Pectinate muscle. Notice how we can see the right atrium filling in part in this inferior vena cava here. What would this chamber be here? This would be part of the
Right atrium.
right atrium, right, because it's above the right ventricle. Right. Now, let's suppose that we made an incision along the right side of the heart and we reflected the free wall back. Now we're looking at the inside, since we're above the tricuspid valve, we're looking at the inside of the right atrium. So this wall here is actually the interatrial septum. Okay? So we're looking inside the right atrium. This opening here is the opening for the coronary sinus. So we call it the coronary sinus ostium. Above it, we see a little depression within the interatrial septum. We call this depression the fossa ovalis. Can you all say fossa?
Fossa.
Fossa is a little depression within the wall. And the reason it exists is because during fetal life, there's an opening there. And the opening is called the foramen. Foramen means opening, you know that already. And it's oval shaped, so foramen ovale. So during fetal life, there's an opening between the right atrium and left atrium. But around the time of birth, in 97% of us, that opening closes, and as a remnant leaves behind a shallow depression, which is now called the fossa ovalis. And there's a reason that there's a little opening during fetal life. During fetal life, you know, our lungs aren't working. We're not exchanging air through the lungs. During fetal life, we're getting our oxygen not from our lungs, but from mom. So that maternal blood that's entering into the umbilical cord is already oxygenated from mom. And as it comes through the inferior vena cava to the right atrium, much of that blood, instead of then traveling to the right ventricle into the lungs, which don't work, it gets shunted through the opening directly to the left side, where the left ventricle can pump it throughout the baby's body. So it's a more efficient pathway, bypassing the pulmonary artery in the lungs. Okay? It's more efficient. In the same way, there is another shunt that's present in fetal life. It's a shunt between the pulmonary trunk and the aorta. So as blood is ejected into the pulmonary trunk, it's already oxygenated from mom. No need to travel to the lungs. So it can pass through this little opening here. It's a little shunt directly to the aorta. This opening, this little passageway, is called the ductus arteriosus. Ductus arteriosus. Now, of course, just like the foramen ovale, the ductus arteriosus closes. Okay? The ductus arteriosus closes at the time of birth and becomes simply a ligament called the ligamentum arteriosum. Because once we're born and we're using our lungs, then we want to go ahead and close off or occlude those shunts. So what you see here in this adult part here is the ligamentum arteriosum, which is no longer open. It's no longer, the term we use is patent, P-A-T-E-N-T. It's no longer patent. In this picture, you can see the superior vein cava coming down, the inferior vein cava, and the coronary sinus. All three veins that drain into the right atrium. And you see the superior surface, the top of the tricuspid valve. Now, if you extend this opening into the right ventricle, below you can see the right ventricle. And you can see its outflow tract into the pulmonary trunk. So that would be the pulmonic valve.
So you said in 97% of people, the foramen
Foraminal
valley
valley
becomes-
remains patent.
Right. So what happens when it doesn't?
We hope that nothing happens, but sometimes stuff happens. Okay, I'll give you an example. Does anybody watch football, professional football? Okay, many years ago there was a Super Bowl that involved the Patriots. And about a week after the Super Bowl, one of their players, Teddy Bruschi, had a stroke. Okay. And the reason he had a stroke was that he had a patent foraminal valve. You know, after the game, you know, these players get beat up quite a bit. This is the last game of the season. So he stayed at bed rest for several days after the game. Now at bed rest, blood flow becomes a little bit more stagnant. And so because he was at bed rest and his legs were kind of swollen, he developed a little clot. And when that clot passed from the leg up the inferior vein cava to the right atrium, because he had a patent foraminal valley, that little clot crossed from the right side. Instead of going to the lungs and being filtered out, it passed directly into the left atrium, down into the left ventricle, and up into the aorta, where it then passed to the brain. Okay. So now the good news is that he recovered, but later they had to close his patent foraminal valley. When a young person like that in their 20s presents with a stroke, one of the first things that we consider is the possibility that they have a patent foraminal valley that allowed a little pinpoint clot to pass to the left side and up into